Thank you very much, Saurabh. You are a modern crow and I am an old crow. But ultimate aim of both of us is keep upgrading your skills. I know in the evening we will celebrate. And the debate between IPOM and eTEP, I think the direction has been absolutely wrong. Why? We started IPOM and IPOM Plus later on. Way back in 1993, Liebrandt had started and we started in 95. Thousands and thousands of cases have been done by IPOM method. Thousands and thousands of meshes have already been placed. Few anecdotal explantations have been done and have been reported. Why? Because it is technically simple, it is minimally invasive, and the most important aspect is high reproducibility. And in last few decades, all of us have seen that mesh can be placed in pre-peritoneal, intraperitoneal, and so on and so forth. But our concern is, and patient's concern is also recurrence. If we had gone from open surgery to IPOM, we were bothered that yes, the recurrence rate at that time or before that time was of the order of 20 to 30%, and it had been reduced to less than 4%, and now we are going back. In this paper by Hotters, prediction of recurrence, we want to improve every time. Yes, there are less than 4% recurrences, but we want to be sure that what were the causes of recurrence and how it can be changed. And the philosophy is that we were thinking when we were doing IPOM repair that you have to cover it by 3 centimeters, then we changed to 5 centimeters, and now most important lesson which we have learned is mesh vis-a-vis defect ratio, and if the ratio is more than 16%, the recurrence rate is bound to be 0%. So we are learning from our mistakes also. But in eTEP, if we go in for eTEP for every case, as has been portrayed by Saurabh, then we have to use the mesh at least 12 times larger than the defect every time. One, yes, new things should come, but I am bothered about old crow versus modern crow. This has come in 2007. This paper was published in 2017, but they never said that all the ventral hernias can be tackled and should be tackled by eTEP method. We are sorry that if we extrapolate this data and then we start saying that for every small 3 centimeters, 2 centimeter, 5 centimeter ventral hernia, eTEP is the answer, I think we are highly mistaken. There is a subset of patients who will require different kind of procedure rather than IPOM only. If we have the comparison between eTEP and IPOM, 27 patients in each series, all of us know just double the time, and we are witness to yesterday's operation also of eTEP. The time taken for eTEP is 186 and the time taken for IPOM is 90. And then the complications also, all of us know that there are unknown complications also and unknown methods of dealing with complications. It is very, very easy. There is a thin line between ethical and unethical practice. Very strong words which I am using, because most of the surgeons who want to sell eTEP, they start saying that if we do not do for 3 centimeter defect, 4 centimeter defect, how will we do in recurrent hernias? But I think there is a thin line between ethical and unethical. We should not say that IPOM is dead and IPOM should not be done and only eTEP is the answer. Once you have done the eTEP, once you have done maybe 4 hours, 3 hours, whatever hours, then you are also placing the mesh. Dr. Saurabh, I got the message that in eTEP you are not using the mesh. No, you are using the mesh but in a different plane. So if the mesh has to be cast in IPOM, but it should not be cast in eTEP, I think it is a wrong notion. And once we are placing in a larger size mesh, the scar tissue development will be there, and If, for God forbid, if I have to go in for doing laparoscopic cholecystectomy later on for that patient because of the large 30 by 30 centimeter mesh which has already been placed in retromuscular plane, it will be challenging for any accomplished surgeon to go in and dig out the gallbladder. It has a steep learning curve. Technically, definitely demanding. If it was reproducible, if it was possible from 2017 to 2019, lot of surgeons would have converted themselves into eTEP surgeons. But technically, it is demanding. And again, if you have done eTEP, and if you have a posterior rectus sheath disruption, maybe in the immediate postoperative period, the chances of complications, chances of intestines moving out of the peritoneum and going on stuck onto the so-called proline mesh is definitely higher. Complications will be higher. And then if you have to go in, first you will have to explant the mesh, and then you do not know what is to be done for the posterior rectus sheath disruption, for example. So management will be different. Many times, most of the surgeons sell that we are putting in a soft proline mesh and you are putting in a proceed mesh, which is cost. To my mind, there is a difference between cost and value. If you are putting in a mesh, and if it is a one-time affair, the patient is absolutely comfortable. I am not saying that adhesions will not form. Adhesions will form in all the meshes, but the patient will be comfortable. So we have to see whether the patient will require re-operations or one-time cost is definitely enough. And for example, now you have done eTEP. You have placed in a 30 by 30 size mesh or more than that even. And if there is a recurrence, what are you going to do? So there are definite procedures which have been explained. Totally endoscopic sublay has been described by Bittner. But again, I would love that you should read in absolutely same. For instance, patients whose retromuscular space is ravaged is the word, after undergoing multiple abdominal approbations may be more suitable for IPOM repair. Further, if in patients with multiple recurrent ventral hernias, severe scar tissue formation after previous operation or large TES or endoscopic surgery is not the answer. Yes, literature about IPOM and IPOM plus is definitely, lot of literature is there, but this is a new crow. One has to have the balanced kind of mind. I would never be happy to sell one procedure for every patient. One has to have the armamentarium, one should know the limitations, and in the end, I would love to conclude before finishing my time that practice till it hurts, keep practicing till it does not hurt. Thank you very much. Thanks a lot.